saying? Okay. Okay, I think we will start now, I guess. Yani, I don't want to be late as well. I want to respect. Okay, someone is asking for the link, just a second. Okay, let's start. Okay. Okay, yeah, let's start. Okay. Sorry. Okay, so like I said, this would be a case presentation. Okay, interesting case that I just encountered recently. Okay, I'm reminding people of our YouTube channel, and this would be hopefully also within in the that YouTube channel. Okay, so that you can review at any point. Okay. Okay. Okay, so let's begin. Okay, so this is a 34 years old female who underwent cardiac screening due to a recent death of her younger sister. Okay, she had non-sustained VT on telemetry monitoring / Holter, and she underwent an echocardiogram which showed the mildly dilated left ventricle with an EF of 43%. Okay, MRI confirmed the minimal dilation of the LV and the minimal dysfunction of the LV, mild to moderate, but there was an extensive subepicardial delayed enhancement. Okay, in the LV, and the RV was normal. Okay, she was an active personnel. And very healthy, never had complaints before. Okay, so this is her initial ECG. This was just 2-3 months ago. Okay, it's a fresh case. Okay, so this is her ECG. It's not a tricky ECG. Quickly, any takers? For example, Sahar, if you wanna, Sumaya, Sahar. Really quick, any concerns with this ECG or anyone else? Mitwalli, anyone?
Okay, Dr. Muhammad.
Yes. So I'll remind you, she's an adult, but young adult. She's only 57 kilos though, okay? Okay. So really quick,
I see it's not sinus, and there is...
she is in sinus or not in sinus, you said?
No, I think it's sinus.
Yes.
And normal axis.
Excellent, okay.
Okay, and there is BECs.
PVCs, right?
Yes.
It's a different QRS complex that is coming prior to the sinus P wave, right?
Yes.
Okay. But that's the sinus P wave. It's a complex that is coming prior to the sinus P wave. And then that P did not conduct. Why is that? Do you see my pointer, by the way, or you don't?
Yeah.
You see? So here. So that P wave did not conduct. Yeah, it did not conduct because of what? Do you know why?
Refractory.
No.
Yes. So because the PVC that came in, so the P wave that came just before that PVC, the ventricle is not ready for another repeat.
It's refractory period. Oh,
yes.
It's
Repeat depolarization. Okay. But this is normal functional block. Okay. And this is the indentation here, is the T wave of that previous QRS. Makes sense, guys? Okay. Now that you know there is families of sudden death and stuff, something that you want to make sure it's not there on the ECG is what QT interval, right? You want to make sure there's nothing funny in terms of QT interval, right? I mean, you cannot measure it online here, but the T waves are in general very flat. And if you want to measure the QT, it's around 450, 455. So it's borderline QT interval, but difficult to measure very accurately because of the flat T waves, especially in V5 and lead 2, where we typically measure the QT interval. Okay. However, the MRI finding doesn't really suggest long QT syndrome, right? There's subepicardial enhancement, usually long QT syndrome, and the dysfunction as well of the LV. Usually long QT syndrome doesn't come with dysfunction of the LV and enhancement. Am I correct, Sahar? Right? There's there's nothing, nothing in terms of arrhythmia concern on that ECG, right? So far.
But when I looked, yes, I think when I see this ECG for the first time and I look to T wave, I'll suspect the long QT.
Yeah, it's borderline, but again, the MRI is not really suggestive of long QT syndrome, right? Something, right, Sahar? Long QT syndrome usually have normal cardiac exam, normal cardiac function, normal cardiac imaging, right?
Yes.
Okay.
Idiotic. So,
it has no cardiomyopathy part of it, right? Okay. Just one thing that you should note, that the QRS are very small, right? Like, this QRS, this QRS, this QRS, the limb lead QRS are tiny, and she's only 57. She's not obese or anything, right? So it's a little bit funny that the QRS are tiny. There is a little bit of, minimal left or even right-sided voltages. In general, the QRS are small, okay? And this is a normal calibration ECG, okay? So, just tiny voltages. There's a one funky PVC. QT interval is borderline, but, it's not, related to the, it's not, doesn't make perfect sense with the clinical or evaluation, okay? So far. So there's another ECG. Okay, this is another ECG, like same day or, very same, short difference in time period. So Sahar, there is another PVC, right? And or Mitwalli,
yes.
one. But that PVC looks different, right? So for example, if I go back, this AVF is positive, right? Lead 2 is positive, for example. And this one, lead 2 is negative and looks wide here and stuff. So different looking QRS, right?
Yes.
PVC, okay? Otherwise, the same ECG with consistent low voltage QRS, okay? And the borderline funny ST T wave morphology, right?
Yes.
Agree? Okay. So, in terms of family history, her younger sister, who initiated that workup, she was 11 years old, died while asleep, and she was a gymnast. Okay, she very healthy, dying while asleep, but with very avid. She was an avid gymnast. Okay, she also has an 18 years old cousin, female, dying as well while she was sitting. She was an active individual as well, dieting. She does cardio, active, but not sick otherwise. And another 28 years old cousin, female as well, dying from having a picture of mild viral infection, like fatigue, shortness of breath, maybe low-grade temperature. We're not very sure. She was also an active individual. She actually arrested at home, and she was, when she arrived to the hospital, she was in VF, and she received four DC shocks, but she eventually had brain death and died because of that. Okay, her EF post-arrest was 20-25%. I don't have the full echo, but report, but apparently normal, normal except decreased function LV. Okay, decreased function LV. Okay, so that's her family history. So then I met this family because of this family history, in order to figure out whether she needs cardiac genetic screening, and if yes, to arrange for it. Okay, because I'm a little bit interested in cardiac genetics. I'm getting interested in cardiac genetics recently. So I met this family, and we ordered arrhythmia panel genetic testing, and it came back with desmoplakin pathogenic loss of function deletion mutation, mutation that results in disrupted desmoplakin protein. And her, in terms of cascade screening, her father is also positive. She has 2 other siblings that are negative, and she has 3 more or 4 more that are pending. Okay, so So now, what is desmoplakin? I mean, I'm guessing most of you never heard of desmoplakin. So desmoplakin is a desmosomal protein, and desmosome is a specialized group of proteins that are responsible for cardiac myocyte to cardiac myocyte adhesion. Okay, and these are this is one cardiac myocyte, and this is another cardiac myocyte. Okay, so there are a group of proteins that are responsible for adhesion between cardiac myocytes. Okay, and these are called desmosomal proteins. Okay, so an example of desmosomal protein is desmoplakin. Okay, another example would be the other four. Okay, these four: desmocolin, desmogliin, plakoglobin, and plakophilin. Okay, plakophilin. Okay, so if you have an issue or a loss of function of one of these proteins, as you would imagine, there might be issue with the cardiac myocyte adhesion between each other, and as a result, there is detachment between cardiac myocytes, fibrosis, inflammation, and muscle mass, death. Okay, so here is another cartoon. So this is again the desmosomal proteins. These are one cardiac myocyte, it's another cardiac myocyte, and the desmosomes again attach cardiac myocytes to each other. And then the space between each cardiac myocyte not only involves the desmosome, there's also gap junctions and sodium channels and other channels, right? So if there's an issue with one desmosome, everything is affected, not just the cell-to-cell detachment, but also the ion channels and gap junctions, and everything gets affected, as you can see here, right? So as a result, makes sense so far, guys?
Yes. Yeah.
As a result, if you have a desmosomal gene mutation that is pathogenic, you will have issues with conduction, electrical conduction between cardiac myocytes, right? Conduction slowing, and we all know that if you have conduction slowing, you're at risk of, cardiac arrhythmia, right? And then you have ion channel issues, then again, you're at risk of cardiac arrhythmias, right? And then, like we said, there is cardiac myocyte death and inflammation, and this would lead to cardiomyopathy, right? So, and then there's through complex pathways, there's also nuclear signaling that would result in adipogenesis and apoptosis of the muscle cells. Okay, so as a result, when you have a desmosomal gene mutation that is pathogenic, you are at risk of cardiomyopathy, meaning some cardiac dysfunction, plus electrical instability, meaning arrhythmias, right? Make sense, guys? Okay, so in other words, if you want to define, so this disease is called arrhythmogenic cardiomyopathy. So if you want to define it, it's a genetic mutation, often involving desmosomal proteins. There are other less common forms of proteins that are non-desmosomal, but are also involved in cell-to-cell binding, that would lead to this similar picture, okay? So it's a genetic mutation, mainly in desmosomal proteins, leading, like we said, to myocardial death or scarring, and often involves the RV, okay? Less often involves the LV, sometimes both, sometimes LV only, but usually RV, okay? So, and then that scarring would predispose the patient to arrhythmia and sudden death, okay? So, and there's incomplete penetrance often. So, arrhythmogenic cardiomyopathy is divided into 3 groups. Arvc, everyone heard of Arvc before, right? This is the famous one,
Yeah,
right?
sure.
Sure. Yeah. Yes,
yeah.
but there is less famous ones that are biventricular or ALVC, which is, the left form of the Arvc, okay? I don't think many people have heard of biventricular and the dominant left ventricular form of the Arvc, okay? Anyways, so in order to diagnose someone with Arvc, that patient would have to satisfy the 2010 International Task Force criteria, okay? With a definitive diagnosis. And I will say what do we mean by definitive diagnosis in a second here, okay? If you wanna diagnose a patient with the biventricular form, then you need the patient to satisfy the RV criteria plus some LV findings that are usually structural or morphological, okay? And if you want to diagnose someone with the dominant LV form of ACM, then you need to have LV structural criteria, which I would show in a second, and you need to have a gene mutation that is, that is known to cause ACM. Okay. Okay. So what is the 2010 International Task Force criteria for ARVC? I would not go into details here because our patient is not ARVC, it's the ALVC, the rarer form. But really quick, because we never discussed ARVC before, you need to, in order to diagnose someone with ARVC, there are a couple of points that you need to look for. Okay, so imaging, there are imaging findings by echo and by MRI. There are tissue biopsy findings, which people don't do anymore as much. There is ECG repolarization abnormalities, the famous ones being T-wave inversion in the right leads. Okay, V1, V2, V3. There is depolarization abnormalities, the famous one being Epsilon Wave. Everyone, I believe, heard of Epsilon Wave before. Okay, there is signal average ECG test that some people would do, but I would not talk about this now. And there is something called terminal activation delay within the QRS. Okay. Again, I will not go into depth into detailed ARVC criteria, okay? So, and then arrhythmia points include non-sustained VT and PVCs, and then family history, including, first degree relative, and if there is a pathogenic mutation in the family, okay? So in order to satisfy a definitive diagnosis for a patient, you need 2 major or 1 major and 2 minor or 4 minor, similar to the, to the rheumatic fever and stuff, okay? Makes sense so far, guys? Okay. So there have been criticism for that criteria. The main criticisms are, there is no mention of late gadolinium enhancement on MRI. If you look at the MRI, it's mainly, volume measurements and dyskinesia, and whether there's dyskinesia or akinesia, okay? Or desynchronous RV contraction. Not hypokinesia, by the way. Hypokinesia is not part of the diagnosis, okay? So sometimes on MRI, the MRI report would say there's hypokinesia. You want to look for the term akinesia or dyskinesia, not hypokinesia, okay? Anyways, but there's no mention of late gadolinium enhancement, which is a criticism. And back then there was, there's no much specifics in terms of which genetic mutation that satisfies the major criteria. And also there is no mention of LV disease. There is no mention of any LV pathology. And like we know now, there is an LV form, there's a biventricular form of ARVC, okay? So so because of such criticism, okay, so before I elaborate here, just really quick, Epsilon Wave, which everyone heard of, is defined as a low amplitude deflection located between the end of the QRS and the onset of the T wave, okay? So between end of the QRS and onset of the T wave, okay? Not within the QRS. Many people, there is an RS-R prime in V1. Many people would call the R prime as an Epsilon wave. You have to be careful. You need, in order to call something an Epsilon wave, it's a deflection beyond the end of the QRS, okay? In V1 and V1 to V3, okay? But, I would not stress so much about Epsilon wave because it has low diagnostic sensitivity, meaning, it only appears when the patient is severely diseased, when the patient is definite ARVC, is end stage, okay? So if you see an Epsilon wave, that patient already satisfied the ARVC criteria way back then and has so many other points, okay? So Epsilon, wave is not really, a super important, clinical finding that you need to look for, because if it's there, this means the diagnosis was super obvious anyways, okay? And because of people confusing it with other waves, it's a little bit discouraged not to focus on Epsilon wave so much, okay? So I would not, I get so many calls. Is there an epsilon wave in a patient which is normal, with a normal echo and stuff? So people overdiagnose epsilon wave, and that's why it's being discouraged. Okay. And I mentioned about the terminal activation delay, and this is the definition. I would not, again, look it up by yourself afterwards, because we're not going to focus on ARVC here. Okay. Okay. So this is in 2020, just like last year, because of the limitations of the 2010 task force criteria, there have been an upgrade to the 2010 task force criteria by the group at the University of Padua in Italy. Okay. And by the way, Italy, they do have so much ARVC. They are they do see so many people with ARVC and other, the biventricular and LV form as well. So they are experts. Okay. So anyway, so they included the late gadolinium enhancement for the ARVC and for the ALVC. Okay. And they included other LV findings such as by echo and ECG, repolarization abnormalities, in this case, inverted T waves in the left precordial leads, because again, there's a left-sided disease, so that you will expect findings in V4 and V6 rather than V1, V2, V3 in ARVC. So usually it's inverted T waves. And there's also, look at this, low QRS voltages in limb leads. So that's a typical finding for ALVC, okay? And if you remember our patient, we did see low voltage QRS in limb leads. Remember, this is the patient's ECG, if you remember. So there's definitely less than 0.5 peak to peak in limb leads. And in terms of T-wave inversions, we do have flattish T-wave. I'm not sure whether it's inverted, it's a flat, biphasic or flat, not really obviously inverted T-waves, but that's okay. Definitely we satisfy the diagnosis anyways, because the patient had PVCs, patient had low QRS voltages, patient had gene mutation, and patient had late gadolinium enhancement on MRI, okay? So if you note, this is the only major criteria. The rest is all minor criteria, okay? So again, in order to satisfy the diagnosis of dominant ALVC, you need LV structural criterion, which is, in other words, you need to have late gadolinium enhancement on MRI, because that's the only structural criteria you have. And then you need an ACM gene mutation. So we have this on MRI, and we have the desmoplakin mutation, pathogenic mutation for our patient. So our patient is ALVC. Make sense, guys? Okay?
Yeah.
Okay.
So, and then they also said that, in order to diagnose ARVC or AVC, you need to have one category. You need, yes, 2 major and 1 minor, 1 major and 2 minor and so forth. But you need to have categories 1 or 2 within those major minor points. But anyways, that's for the ARVC. We'll not talk about ARVC so much anymore. So our patient definitely satisfies the criteria for ALVC. Okay. So again, there is usually for ALVC late gadolinium enhancement. There, if you do biopsy, you might see fibrofatty infiltration of the LV, and then there's low voltage QRS and sometimes T-wave inversion. So all patients with ALVC should have LGE in order to satisfy the diagnosis of ALVC, okay? And then the more LGE you have, the more systolic dysfunction you will get, and then the more cardiomyopathy or decreased function you will see, okay? So initially, it's mainly fibrosis, and then the fibrosis often is related to arrhythmia, and then more and more fibrosis, then you get, cardiomyopathy. So arrhythmia first, and then cardiomyopathy later, okay? Okay, so any questions so far? Okay. I'm a little bit quick because there are so many slides, but I might be very quick, so stop me if I'm very quick, okay? Okay, so some history. So the ARVC, which is the commonest form, have been described since 1700s, believe it or not, okay? However, the first major paper regarding ARVC was in 1982. Okay, so it was a report of 24 adult patients with cardiac replacement with fibrofatty tissue of the RV, thinned wall RV. Initially, people confused it with Yule's anomaly, which is, everyone knows what's Yule's anomaly, right? So it's a dysplasia of the RV. So this is why initially the naming of ARVC was initially named as ARVD, okay? Because they thought there is a right ventricular dysplasia like Yule's anomaly, but in addition, there was VT as well, okay? So initially people called it ARVD or RV dysplasia. And then arrhythmia was very common. Then they added the arrhythmia to the right ventricular dysplasia. And then, only recently people recognized the LV disease, and then now it's called arrhythmogenic cardiomyopathy. And then you subtype it into ARVC, biventricular, or ALVC. Okay. Okay. So it's a progressive disease. So patients are usually born normal. Okay, you have a normal cardiac exam and cardiac imaging at birth, and then usually at teen, after puberty, usually after puberty, then you start having epicardial fibrosis, and then that progresses depending on the patient into transmural scarring, and then eventually thinning out of the myocardium, okay, whether it's in the RV or the LV, okay, guys? So it's a progressive disease. You're born normal, and then you might develop the disease that worsens with time, okay? So what accelerates that progression is often related to endurance exercise, okay? Especially for ARVC, the right form, it has been very well known. The more you exercise, the more you accelerate the disease, okay? In addition, if you are a male, testosterone is a bad actor. Testosterone apparently accelerates ARVC. And then if you have multiple gene mutations, then you are more likely to have disease that presents, early on, and to suffer from significant morbidity and mortality from that disease, okay, from that mutation, okay. So in terms of exercise, again, this has been confirmed by many studies. The more you exercise for ARVC, the more likely you would develop the disease if you have the substrate for it, okay. So for example here, the more hours per year you exercise, the more you would meet the task force criteria for ARVC, okay? If you are an endurance athlete, the more you would satisfy criteria for the task force criteria for ARVC. Again, if you have the substrate for it, okay? If you have the gene for it, if you have something that that might develop into ARVC, okay? Not only this, it also affects your clinical course. For example, if you are an athlete and you're developing ARVC and you get sustained VT or VF, you're less likely to survive that attack, that arrhythmia, okay? Plus, if you are an ARVC and you're an athlete and you develop heart failure, you're less likely to survive the heart failure, okay? So it accelerates the disease progression and also alters the clinical course of the disease as well, okay? However, there are patients with the substrate for ARVC and they exercise like crazy, but they are fine. So there are other factors that people don't know yet, okay? But hopefully we will understand the disease better with time, okay? Remember, it's just recently been described, okay? The initial major paper was only 1982, okay? So, for example, these are two family cohorts, ARVC family cohorts, okay? So patient one who exercises so much, okay? This arrow means VT onset, had a VT, and then the solid line means that the patient satisfied the criteria or was officially diagnosed as ARVC based on the International Task Force criteria. So that patient who exercised so much, satisfied the diagnosis. His siblings and other family members who are not exercising as much, they, for example, this patient did not satisfy the criteria. This patient did not. This one only, after many years satisfied the criteria. This is the criteria. This is the onset of the disease here was below 25, and here is above 40. Right? Makes sense. This shadow here is what is the AHA recommendation for exercising, minimal exercise. Okay, so if you are below AHA guidelines, you in general you're fine. If you're above the AHA guidelines, it might be an issue for you. Okay. Again, another cohort or another family cohort. This individual exercised, so much, and then had VT onset and satisfied the diagnosis. The other two family members do not exercise so much and never satisfy the diagnosis. Okay. Okay, guys. So again, the take-home messages for ARVC, exercise. This is one of the main diseases that exercise doesn't go well. Okay. Other diseases include long QT syndrome, for example. Many people have been not discouraging exercise anymore. Okay. But ARVC specifically, exercise is what is really not a very good idea. I mean, extensive exercise, above the AHA recommended guidelines. Okay, not minimal exercise, only above the AHA recommended guidelines. Okay. And again, if you have ARVC and you are an athlete and you have an ICD, and then you stop exercising, your incidence of VT after you stop exercising gets less. Okay, this is what we're trying to tell you here. Okay, so if you, even after you develop let's say you are an athlete, you developed ARVC, when you stop exercising, your clinical outcome improves. Okay, so it's definitely exercise, even when even after you already had VT and ARVC, you stop exercising, you improve the patient. Okay, so exercise is really bad for ARVC. Okay. So genetics are very interesting for ARVC. So any questions about exercise, by the way, guys, before moving into genetics?
No, it's okay.
Clear? Am I too fast? Everything's good?
No chest pain at all, Dr. Muhammad. No history of chest pain at all, because of all of this fibrosis and all of this.
Well, I will. Good question. I will talk about chest pain in a second. Okay. Good question. Okay. Okay. So genetics, it all started in the island of Naxos, which is in Greece. Okay. We should visit one day in Greece. I should visit Greece one day. So there were two smart physician couples. Okay. They noted patients with very thick hair and thick skin. Okay. And then those patients would develop VT. Okay. And then cardiac evaluation would suggest ARVC VT. Okay. Remember, the ARVC has already been described. Okay. This was in beginning of 1980s. Okay. So then they said, these patients are having skin disease, hair disease, and cardiac disease. What do these two systems share? They do share desmosome. So desmosomal proteins are also present in skin cells. Okay. Again, they hold the skin together. Okay. So, but only 14 years later, this group and others diagnosed the plakoglobin, which is one desmosomal proteins, like we said. Remember, plakoglobin diagnosed a mutation or deletion mutation in plakoglobin that is happening in these patients. So patients, again, with skin disease, hair disease, and ARVC, this was only in 2000. Okay, so the first identified desmosomal protein mutation for that, for these patients were plakoglobin. Okay, and this was called Naxos disease. But then only beyond 2000 where the other proteins were developed. Okay, So it turns out that Knox's disease is actually an autosomal recessive form. You need to have 2 mutations in plakoglobin to develop Knox's disease with the cutaneous manifestation. So it's an ARVC patient with the cutaneous manifestation that we talked about, okay? And then there is Carvajal syndrome, which is autosomal recessive mutation in desmoplakin, such as the patients are having ALVC with the cutaneous manifestations, okay? Makes sense, guys? Our patient did not have any cutaneous manifestations, by the way, or skin, issues, or hair issues, okay? So, so if you heard of Carvajal and Knox's disease or syndrome, this is what it is, okay? So it's like Jervell-Lange-Nielsen syndrome for long QT, where it's an autosomal recessive long QT syndrome, right? Yeah, with hearing defect. This is autosomal recessive form of ARVC and ALVC with skin and hair, defects. Make sense?
Yeah.
Yeah. Is it too complex or easy so far?
No, we had the family before woolly hair syndrome.
Where?
Long time ago.
Really?
Here, kind of Dr. Fatma, Dr. Amira's patient, late Dr. Amira.
So what did we do with Danny? Do you know?
At that time, we didn't.
So
anyhow, the girl, young girl with the cardiomyopathy, her sisters woolly hair also, but they were normal.
Interesting.
But yes, and as far as I remember, not all criteria were, and we didn't send for genetics. They were non-quantity.
Well, this was which year? This was many years ago, right?
Long, long time ago.
There was not even, remember the first gene mutation that was discovered was in 2000, so these are all new diseases, new gene mutations, okay? Remember, so you're talking beyond 2000, so.
After 2000, but still we didn't, it was not mentioned clearly that what gene we have to search for.
Yeah. Okay, now we know. Okay, so next time you see woolly hair patient, let me know.
Yeah.
Because I have never seen it before. I don't know whether, again, we have Dr. Fatma, who's an EP from Lebanon, very smart EP from Lebanon. I don't know whether you had seen this disease, but I have never seen Knox's or Carvajal syndrome. Anyways, okay. So there are broader definition for ACM, okay? That, some people might use, which includes any disease that causes cardiomyopathy with arrhythmia, okay? For example, sarcoidosis, for example, myocarditis, for example, Chagas disease, if you remember it from med school, this is, in South America, other gene mutations and channelopathies, okay? So this is a broader definition that some people might use for ACM, okay? But the typical definition is what we said, the desmosomal proteins causing ARVC or ALVC or biventricular, okay? Okay, so if you want to use that broader definition, desmosomal gene mutations represent 40 to 50% of the patients, okay? These 5 desmosomal proteins. And then 20 to 30% represent the other forms, okay? Non-desmosomal forms, the, like we said, the myocarditis and so forth. And there are idiopathic cases, okay? Okay. So, so if you have a patient with ventricular dysfunction and arrhythmia, then by definition, he's arrhythmogenic cardiomyopathy. And then you have to figure him out in terms of which type of ACM is he, okay? Okay. So I will skip through these slides, but really quick, there are mimickers of ARVC listed here, okay? So just be aware of them. There are a couple of conditions that might mimic ARVC that you need to think of whenever you encounter a patient with ARVC, okay? And for example, Brugada syndrome might mimic ARVC in terms of T-wave inversion, the right leads, for example. Athlete's heart might mimic ARVC. I will not go into details because if this is all one lecture by itself, okay? And DCM mimics ALVC. Like, for example, our patient, initially people thought it's a DCM case without much dilation, okay? But, it's not DCM, it's an ALVC, okay? So the main, I'll focus here, I'll just say the difference because it's an ALVC case. So the main difference between DCM and ALVC is that ALVC, the issue are mainly arrhythmia, and the dysfunction and dilation is very late and not that significant, okay? Versus DCM, usually the dysfunction is severe and the arrhythmia never comes or rarely comes at the end stage. Okay, guys? Makes sense? That's the main difference. Plus, on ECG, you have the low voltage QRS in ALVC, and initially for DCM, at least initially, you have increased voltages. Then, only then when the myocardium is really thinned out, then you have decreased voltages. Okay, guys? So
for dilated cardiomyopathy, sometimes dilated cardiomyopathy induced arrhythmias.
Yeah, but late.
Arrhythmias in the stages, yes.
Yeah, it's late.
Yeah.
For ALVC, it's, arrhythmia is very predominant. For DCM, the dysfunction is very predominant. So this is the main difference. Okay.
Okay.
There are MRI differences as well, and other differences. The type of arrhythmia might be different in both, and so forth. Okay. But MRI is very important. Genetics is very important difference because the genes in DCM is different than genes in ALVC. MRI findings are different. And Dr. Bahia would tell you the differences, but I invited her to attend this class. I don't know whether she's here, but anyways,
she's here.
Oh, she's here. Okay, welcome, Dr.
Okay.
Bahia. So there are differences, but for us clinicians, ECGs and the clinical manifestation is different. Okay, okay, okay. So these are some of the genes that are causing ACM and their phenotype. I will not go into detail here because just for your reference here. Okay, again, we have so many slides. I want to be sure I'll be done within 1 hour. Okay, so this cartoon just tells you how complex it is. That's why there are so many genes that are involved in ACM, because every gene and every protein is interacting with each other somehow. Okay. So eventually, you might have similar phenotype but different genotype because of this complex interaction. Okay. Okay. So desmoplakin cardiomyopathy is a very recent, disease. Okay. So this is the largest study in DSP patients to date. Okay. This is only in 2020. This is just last year. Okay. And mind you, this is DSP mutations. These are not DSP. They not all of them satisfied the PADO criteria for ALVC. Okay, these are just patients with a DSP mutation, genetic DSP mutation, but some of them did not develop the disease at the time of the study. Okay, or like they may never develop the disease. We don't know. Okay, but anyway, this involved 107 patients that do have DSP pathogenic mutation. Okay. And they compared them to 81 patients with PKP2 mutation, which is typical for ARVC. It's another desmosomal protein that we mentioned that is typical, that gives you mainly ARVC. Okay, so there's the one gene that gives you mainly ALVC and one gene that gives you mainly ARVC, and they're comparing them with each other. Okay, guys? Okay, so they did notice, and this is Sahar, this is back to your question. You said chest pain. In fact, DSP cardiomyopathy patients often do have history of chest pain that people might think it was a clinical or subclinical or clinical viral myocarditis. Okay, so they do have evidence of chest pain and troponin leak or inflammation within that cohort, and which is very important to note. Okay, so you remember that the desmoplakin mutation, like we said, leads to cell-to-cell detachment, and that creates inflammation with troponin leak and cardiac death. And then this, if it's significant enough, would cause chest pain, and people might present to ER with chest pain. People think it's viral myocarditis, they dismissed it, they just send them back home, and then this repeats itself a couple of times until they manifest the disease. Okay, okay. Anyway, so there is fibrosis that is progressive and then dysfunction. So this is different than DCM, where there is dysfunction and then fibrosis comes in late. Okay, so that's the difference. Okay, and there's again, you know, MRI differences between DCM and ALVC, and then ischemia, myocarditis, and HCM. That, you know, this is for your reference. And just so you know, this is why I always request for MRI for our funny cardiomyopathy patients, our patients with arrhythmias, looking for such differences. Okay, people must think, why do we do, like Mitwali, there's just the other day, remember when I have DCM patient and I told you, we need an MRI? That's why.
Yes.
Okay,
Yeah.
remember? Okay. Anyways, so okay, so the females have been more, you know, there are around 70% of patients of DSP carriers that were females. So there is for some reason, there are more females than males, but the females did not manifest, they did not have more disease burden. It's just they were more frequent for some reason. Okay. And remember, in our patient, all the, you know, all the death, at least the death, were females for some reason as well, which I'm not very sure we understand. Okay, usually, you know, the typical age of presentation is the mid-30s. Okay, so for the DSP, 36% had normal function, versus for the PKP2, 60% had normal function. So again, DSP, they have less normal function compared to the PKP2. Okay. Of course, DSP have had more, 51% of them had LV, a predominant form disease. And look at PKP2, 0 had LV form, predominant disease. Okay. And then RV predominant were only few, and the rest is by V. Okay. So PKP2 predominantly, RV predominant. Okay. Okay, look at this. So the skin and hair findings were present 55% of such patients. Okay, even in autosomal dominant mutation, for some reason they did note the skin and hair manifestations in those patients as well. So not only in autosomal recessive mutation, also in autosomal dominant mutations as well. So which is interesting. Okay. Anyway, so if you want to use ARVC criteria for this DSP patients, you will only satisfy you will only have definite diagnosis in 34%. Okay, so not much compared to 49% for PKP2. Okay, so the chest pain, look at this, Sahar. So 20% had chest pain and 15% of them had troponin leak at some point, versus almost no one in PKP2. Okay, so for some reason, there's more troponin leak in DSP compared to PKP2. Okay. And as expected, there's more T-wave, the T-wave inversion in V4, V6 is more in V4, V6 compared to V1, V3. So 21 versus 8%. Okay. Anyways, PVC, 56% had frequent PVCs and 61% PKP2. And then late gadolinium enhancement, 40% of those patients, 107, had late gadolinium enhancement findings. So if you want to be strict about diagnosing ALVC, only 40% of those DSP patients had the ALVC. Okay, so not all 107, roughly maybe 42 of them. Okay. Because remember, to satisfy ALVC criteria, remember, you need to have LGE, LV, LGE to satisfy the diagnosis. Remember the diagnosis, the criteria we mentioned. Okay, so that's the only major criteria, and you have to have it. Okay, so so that cohort, only represent 40% of ALVC. The rest are only desmoplakin mutation without ALV, without disease manifestation. Okay, that's why there's incomplete penetrance. There are patients who have the gene, but they never develop the disease, or only develop the disease if they are super athlete or for any other reasons. Okay, okay, and then VT. So VT defined as sudden cardiac death or ICD therapy, or VT, clinical VT, happened in 30% or 28%, around 30% in both. Okay, okay. So again, so there is evidence of intermittent. Do you hear me, guys? Internet is okay?
Yeah, it was slow, but now it's okay.
Yes, yes,
okay.
yes.
Okay, so there is evidence of intermittent inflammatory episodes at least in DSP. Okay. Okay. So okay. So one reason why PKP2 patient never had chest, they did not. Maybe one theory would be that RV ischemia might be less painful, and patients just don't show up to ERs, and then hence you don't see troponin leak. Okay, so that's one hypothesis why that the discrepancy between both groups. Okay. Anyway, so for DSP, so this is only for DSP patients, desmoplakin. Many had the predominant RV form had LV dysfunction 50%. So there's so much LV disease in desmoplakin, even among the predominant RV form. Okay. And then among the predominant LV form, 31% had RV dysfunction. So so it involves both ventricles more often than your PKP2 group. Okay. They do have frequent PVCs. They do have late gadolinium enhancement, like we said, and especially if it's the LV form, they do have more compared to the predominant RV form. Okay. So PKP2, only 5 or 6% of the patients with PKP2 had LV involvement. Okay, so PKP2 really is selective for RV. DSP, only 4% had isolated RV. Okay, so it's like complete opposite. Okay. So the penetrance of the disease is around 50%, roughly 57%. Okay, so not all patients with the gene would develop disease, and the penetrance for PKP2 was a little bit lower. It was around 28%. Okay, so DSP for some reason is more penetrant. Okay. So I don't want to complicate things here, but I'll just summarize the table really quick. So this table is comparing proband, meaning the patient who the first patient within a family that presented. Okay, so the probands obviously would have, because they presented first, so usually you would expect them to have more LV disease, right? So they have more LV enlargement, more systolic dysfunction compared to non-probands. Okay, so that makes sense. Okay. And like we said, T-wave inversion is more in probands. That's why they were probably diagnosed, okay? Or this helped in their diagnosis. And more PVCs, maybe symptomatic PVCs, okay? More VT compared to non-probands, okay? Okay, so that's easy. What was interesting, that exercise data was not similar to the Arvc. Okay, so if you look at this, 35% of the probands, which are more symptomatic, describe moderate to intense exercise history, compared to 63% of non-probands who are less symptomatic describe they were active. So this was interesting. In other words, exercise, at least in this study, exercise did not seem to affect DSP cardiomyopathy. Okay, so the exercise was not really associated with a greater risk for experiencing severe VT or dysfunction or being symptomatic, okay, or manifesting the disease for some reason. Okay, although in our case, all the 3 that died were active. Okay, so this is a little bit not consistent with our limited experience, at least. Okay, there have been mice model that there is a mice with DSP mutation, intentional DSP mutation, and treadmill exercise study. Okay, and then they noted that this mice with treadmill exercise, his inflammation and cardiomyopathy improved. So after intense exercise training. So again, this supports that DSP patients, for some reason, exercise is not affecting them. Okay, so this is in contrast to Arvc. Like we said, Arvc is exercise definitely bad for them. For Alvc, DSP specifically, we're not very sure. I mean, I still would recommend patients to, I still recommend it for this family to be within the AHA guidelines and not to exceed the AHA guidelines until we further, clarify that, okay? And especially for our patient family, again, those who were the most active had the disease. So again, there's discrepancy here, okay? And there's no other studies to, yes, sorry, who's this?
Just one question. Do you think the low number, like around 80 patients,
Yeah.
I think just doesn't justify to generalize the findings of the study,
Right.
I guess.
Yeah. But it's a very rare disease, I mean, I agree. Have you seen it, DSP cardiomyopathy, by the way, Dr. Fatma?
Not really. So there were some other kinds of genetic mutation associated with Arvc. I haven't seen Alvc per se during my training, but just reading it in the literature. It's really very rare. And I thought you were lucky to find that, but very unlucky for the family. And I think you need, I'm sure you're planning to report that mutation, right?
Yeah. You mean report? What do you mean by report? You report to where?
To the literature. Just due to the genetic
it's
reasons.
a big family. It's a very big
Yeah.
family where we're still waiting. We're still doing cascade screening and stuff.
Yeah.
Yes, but eventually, hopefully.
Yeah, and I'm also curious to know the findings of the dad.
Dad was positive. His
Yeah.
his EF was around 55%, so minimal decrease in EF, and he had he had the epicardial enhancement as well. So Dad does have less than the proband, but Dad has not been active in general and asymptomatic. He did not do a Holter yet or exercise stress test. This family has been diagnosed just 2-3 months ago, so it's recent. They are still in shock, and we are not at the stage where we're doing extensive Holters, exercise stress tests and stuff. Hopefully, in a couple of months we will be able to do it. But so far, Dad has MRI findings and gene positive, but asymptomatic, and he's not on any meds or has an ICD. Okay. He has a big, I don't remember now, but he has a couple of brothers and sisters, and two cousins died. So one of their parents do have the mutation, of course. They're obligate carriers, so it will be a big family. Eventually it will be a very big family if we can get them all. Okay.
Yeah. Interesting.
Okay. Yeah. So in terms of variables that have been associated with VT in this study, any decrease in EF, so even less than 55%, have been strongly or statistically significant in terms of arrhythmia development. Okay, so Dad, for example, his EF was 55, if I remember correctly. So he's still not very immune in terms of VT. Okay, so I'm a little bit worried about him. Anyways, PVCs and any dysfunction in LV is a risk factor. Okay. Statistically significant. Okay, and for PKP2, RV dysfunction and PVCs have also been statistically significant for VT. Okay, so that makes sense. Okay, so for the DSP cohort, if you have LV dysfunction, you're at risk of developing VT, and for the ARVC cohort, if you have RV dysfunction, you're at risk of developing VT. Okay, so this is for you, Fatma. I don't think others would be, that would not be very, relevant to them. So one recent, well, it's not recent, it has been published 2014, but apparently if you use a very high dose isoproterenol testing, like 45 mics, imagine, apparently ARVC, at least, they develop, so much ectopy that is not seen in idiopathic VT or any other form of VT. Okay, so apparently this has been a very and has been validated by other centers as well. So high dose isoproterenol testing, if you're not very sure this patient, you have a patient with cardiomyopathy and VT, and you're not sure is it ARVC or something else, apparently high dose isoprenolol might be helpful. Okay, anyways, let's skip through this. So if you,
also using polymorphic PVCs, it looks like.
yeah,
Yeah.
polymorphic, but from the RV. And for idiopathic VT, it's usually usually one form and so
Yeah,
forth.
monomorphic.
Okay? Yeah. Okay. So now we have a patient with ARVC or ALVC. Let's focus about ALVC a little bit here. But in general, if you have a patient with ARVC or ALVC, this is the your main question would be, does this patient needs an ICD or not? Because there's nothing else that has been proven to be to be effective in terms of reducing risk of sudden death. Okay, so obviously if this patient had a history of aborted sudden cardiac death, he definitely needs an ICD. If he had sustained VT, definitely needs an ICD. If he has severe dysfunction of RV, LV, or both, he definitely needs an ICD. So that's it's a given. Okay. If you have, nothing, if you have syncope, non-sustained VT, moderate dysfunction, you're at intermediate risk, and then most people would throw in an ICD, especially if the age, permits. Okay, usually the age permits because they usually manifest after puberty. Okay, and so forth. Okay, so that's the biggest question for us, and this is a rough guideline. Okay. So management, you estimate the arrhythmia risk based on what we just said, and there's also a risk calculator that you can use. And then your big question, needs an ICD or not. But be aware that you do a good MRI before the ICD, even if it's compatible, but just because of artifact and stuff. Okay, so of course you do MRI and everything, and then you do the ICD. And after the ICD is inserted and the patient has PVCs or VT, you give beta blockers, and then you can do sotalol or flecainide if beta blockers were not sufficient, and then you might consider even catheter ablation, though results are not great. Okay, this is in 2019. So one recent effective management was sympathectomy, like we know that works good as well for long QT syndrome, type 1 especially, but even maybe type 2. This works very well for preliminary data, does show that for ARVC, we're not talking about ALVC, we don't know about ALVC yet, but ARVC, sympathectomy is a good option. Okay. And then, of course, if there is cardiac dysfunction, you give the heart failure meds, including ACE inhibitors. Okay. Okay, so now like we said, your big question would be, does he need an ICD? If yes, what type of ICD? We discussed this before, just to refresh your memory. There's transvenous form and there's subcutaneous form. Okay, issues in both forms that, if you remember, the QRSs are small, right? So the machine, the ICD, measures that QRS. If it's small and the T waves such that it's equal to the P wave or the T wave, the machine might be confused in terms to determine what is P, what is QRS, what is T, because they're all the same size. Okay, so if the QR, like we know that part of the disease, especially the ALVC, the QRSs are small, so you might have issue with the machine being able to sense the normal sinus rhythm. Okay. In other words, the machine might overtreat the patient. Okay, might call, something, someone is sinus tachycardia, might give him a shock because, the machine thought he's in VT. Okay, so there is definitely sensing issues for both, and because of the fibrofatty replacement, inflammation, scarring, there might be capture issues. You might, if there's a scar that is developing where the lead is inserting, you will not capture the myocardium, right? So there's this issue for transvenous or subcutaneous. But the transvenous advantage is that for the transvenous, there's an option called ATP, which is anti-tachycardia pacing, meaning you pace faster than tachycardia and then hopefully it breaks. Sometimes like we do it, in the ICU, someone is in flutter, you pace fast, it terminates the flutter. So that ATP feature is possible for the transvenous type, but not for the subcutaneous type, okay? Of course, perforation is a concern because, again, there's thinning of the myocardium. Although usually the apex is not very involved, and usually we insert the lead in the apex and this or the septum, so it's less, it's not where the disease is active. Still, if the lead is in the not the apex, more towards the free wall or anterior wall, you might risk perforation because of thinning of the myocardium because of that, because of the fibrofatty replacement. Okay, and for the subcutaneous form, again, there's more sensing issues because it's further away from the heart compared to the transvenous form and so forth. But definitely both are effective in terms of shocking a patient in VT. Okay, they are usually effective, but they might overtreat. Okay, make sense, guys?
Yes, just one question here.
Yeah.
Do you advise the subcutaneous for mild to moderate dysfunction and more severe type of dysfunction to go for the endocardial?
Well, if the patient had, never had VT, like primary prevention, like you think you will not, hopefully you will not develop VT or never develop VT, then, subcutaneous is a good option. But if the patient had, VT and secondary prevention, maybe the transvenous is better. In our patient, we gave her subcutaneous ICD because she never had VT. And of course, that to spare the venous route for maybe later use, But I think subcutaneous ICD makes more sense. Just we might overtreat, she might develop, she might receive a shock inappropriately. That's the concern. But so far so good. And this report, it's did not. I mean, this is in 2018. The rate of inappropriate shock was similar to other diseases. It's still within the accepted range for subcutaneous ICD. So it wasn't really that of a concern. It's a theoretical concern, but no, I don't think it manifested, or clinically or in real life. Okay.
Yeah, especially that you also test the DFT with the subcutaneous.
Yeah.
I assume so.
Yeah. Okay. So in conclusion, good. We're almost on time. Okay. Conclusion. So you want to diagnose the patients early, again, to prevent the progression or help slow down the progression. For example, let's say for this family, for example, there is a 10-year-old brother who is still genotype pending, but if he, God forbid, has the gene, I might try to persuade him not to go into exercise, not to go into heavy endurance exercise routine, rather maybe some other forms of exercise, for example. So it's nice to diagnose patients early so that imagine someone who's 20 years old, who's already an athlete in this specific team, and he's, and he is paid, because he's part of this team, or he's a scholar, he has a sports scholarship, and then you tell him you cannot play, basketball anymore. That would be very, 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 obviously he might not comply because, he has been practicing basketball for almost his entire life. Versus if you start early, before he develops any interest in a specific sport, you just persuade him or guide him which sports are good, which sports are not good for you. Okay. So diagnosing early is a key. Of course, you have to avoid over or under diagnosing. You have to be smart and only diagnose when you think the patient has the disease. Okay. Okay. So remember, the T-wave inversion criteria applies for individuals who are above 14, because we pediatrician, T-wave inversion less than in pediatrics is normal. Okay. So that T-wave inversion criteria is not very applicable to us. Okay. Often because the disease usually manifests beyond puberty, often what we will see is the dad has a disease and you'll see his kids. Okay. But for example, in this case, I'm seeing the younger brother. This is how I met the family plus the genetics part of it. Okay. So you have to confirm that the adult patient really has the disease. Okay. So don't trust anyone who diagnose someone with ARVC or ALVC just because it's in his notes. Okay? You have to make sure on what basis was this patient diagnosed, and then go from there. Okay, because remember, it's a major criteria. Family history is a major criteria. So if you take it for granted, and let's say dad did not really have an ARVC, and you assumed he had an ARVC based on the adult physician who diagnosed him, you will give this patient one major criteria, and then he might be diagnosed inappropriately easier or overdiagnosed easier. Okay, you have to review the MRI report with an expert. So for example, in this family, the couple of MRIs has been reported as normal. However, an expert, Dr. Bahia, since she's here, reviewed the MRI, and in fact, it was there was some enhancement that was not seen previously. Okay, so there was modification of the report after an expert reviewed the MRI. So that subepicardial enhancement is tricky, and you need someone with experience to study that MRI. Okay. Genetic reports, of course, we all know that genetics are complex, and whenever you receive a genetic report, you have to study that genetic report. You have to make sure it matches your phenotype. Okay, the phenotype of the patient, and consult with more experts, and again make sure that gene report, that pathogenic or likely pathogenic mutation is really pathogenic. Okay. So you have to re-study the genetic report as well. Okay. And then because the disease is progressive and usually starts at puberty, you don't have to go crazy in terms of screening family members that are very young. If there is a gene mutation, you just go do genetics. If it's positive, then you do screening every couple of years. If it's negative, then you don't worry about it. Okay. And if there's no specific gene, then you screen them every couple of years. You don't have to do it every 3 months or 6 months or so, and so forth. Okay. Okay. So unfortunately, sometimes the first warning sign for children is arrhythmia. And like in this family, this 11 years old sister, died suddenly. Okay. And she's only 11. So unfortunately, she did not manifest any symptoms or signs that people, alarmed people. Okay. So she just suddenly died. So unfortunately, sometimes that's the initial manifestation, which, that you cannot do anything about. But more frequently, there are PVCs, non-sustained VT, that would show up. Okay. That as the first sign. Okay. Now, unusual to have a sudden cardiac event or death without meeting the criteria. Usually you need to have so much, major, minor points to develop, sudden cardiac death. So this is the more typical. Okay. There is antibody for DSG, desmosomal protein, that is in research. It's only research based, but there are antibodies that, if present, this also would help clarify whether the patient has ARVC or not. Okay, DSG type ARVC. So this is just research preliminary, but in the future this would be helpful for the further. Would be helpful for us to diagnose patients more appropriately, more better. Okay. You have to remember, any LV dysfunction in DSP, cardiomyopathy, is associated with VT risk. Okay, so any dysfunction and PVC is associated with VT risk or sudden cardiac death. Okay. Okay, so in summary, ALVC, it's a small figure. Sorry. So ALVC, you will see low voltage QRSs, you will see subepicardial enhancement, you will see T-wave inversion, you'll see PVCs, you'll see VT. Okay, so these are what you look for, and these are the common desmosomal and non-desmosomal proteins that might cause ALVC specifically. Okay.
Do we see epsilon waves also in ALVC?
No, it's more right side ARVC. Epsilon wave is more ARVC. Okay, and again, epsilon wave is not really I would not focus on epsilon wave like
Pathognomonic,
yeah. So
not pathognomonic.
yeah. So our goal is to encourage people to of course, I hate to tell our patients not to exercise, okay? So our goal, of course, to encourage patients to exercise, but you know, for soccer fans, you know, Antonio, I mean, he was I think Eshbilia, I guess it's Eshbilia. He's a player from Eshbilia who died suddenly in 2007, and he had Arvc in the field. And then we all, you know, had seen Euro 2021 or 2020, and we saw, you know, a player who collapsed in the field, and we don't know what, you know, we don't know what he has, but he, you know, he might have Arvc or ALVC or some other form of disease that presented with VT or VF, okay? And, you know, this player, for example, I'm sure he had extensive cardiac screening in Italy. He played in Italy and England. And in Italy, like I said, they are very famous for Arvc. They know how to diagnose Arvc, okay? And they screen all their athletes with ECGs and echo, I think an echo as well. So, and he, you know, he somehow was never diagnosed with anything, okay? So anyway, so these diseases might be tricky, okay? Might miss, you know, screening programs, okay? And these are, you know, tragic examples. I mean, I'm glad, you know, Erickson is fine now, but, you know, not everyone, you know, is fine after after a sudden of cardiac event, okay? Okay, so, okay, so just I talked about, I mentioned so much endurance exercise and you know, this is what we meant, you know, the more dynamic component there is, the more endurance exercise it is, okay? So, you know, so you don't want to go towards the right side of the screen. We prefer the left side of the screen, okay? But this is only for your reference. And endurance exercise defined as, you know, sport with moderate to high dynamic demand, okay? So you want the patient to be more on this side of the screen. And if you look at these, you know, these options are very, although gymnastics is here, by the way, but, you know, it all depends on what type of gymnastics, how is she, you know, was she trained and so forth. But anyways, you know, such types of exercise is not very popular, okay? But you have to try to encourage people to go this route versus, you know, versus this route, okay? But the most famous sports, you know, for soccer, for example, it's very highly endurance exercise, okay? Okay. And again, another you know, endurance exercises, and which one is the most, you know, most endurance exercise within sports, okay? So soccer is very, you know, up there. It's a high intensity sport. Okay, so we're done. So our patient eventually had a subcutaneous ICD just recently, and so far so good, okay? And she's also seeing an adult cardiologist who specializes in cardiomyopathy, or like heart failure, sorry. So she's on, you know, afterload reduction agents, and I think she was on Lasix as well. But anyways, so she is being managed for her heart dysfunction, and she has an ICD and a beta blocker, but she never had VT. She had non-sustained VT, but she never had sustained VT. So beta blocker for her is more than enough for now. Okay. I don't know. I'm
heart
guessing,
failure, I think.
Yeah, I'm guessing she's in metoprolol, I think, or carvedilol, one of them, I think.
Metoprolol also.
Yeah. So I mean, I don't remember now, but one of them. Okay. Okay. So we're hopefully we will. So we might see, the reason why I'm presenting this patient to our group, because, you know, we might see the siblings and the cousins and so forth. And if you see, you know, ALVC, now at least you know what we are looking for and so forth, okay? Okay, questions?
The only thing is, what I understood, if these patients, we shouldn't send for exercise ECG or...
well, it's a controlled environment, and I do them, and usually if I see something crazy, I stop, you know, I don't make them go into malignant arrhythmias, you know. So usually it's not an abrupt, usually there are signs before something happens, but this is not, ALVC or ARVC is usually not like CPPT, in which with extreme peak exercise, you get something, it's not related. Yes, exercise is not good for you, but it's not, exercise just causes more scarring, and then that scar would lead to death, okay? But during active exercise, usually there is not much manifestations. Okay, makes sense. So I will not be very worried if I stress them. Okay, I'm more worried for CPVT patients to stress them. And then if you see something, you can always stop. Usually it's not like from clean ECG to sudden VF. Usually there are markers before VF. So yes, you can exercise stress test them or exercise test them, but the value of exercise stress test for ARVC and ALVC is not great compared to CPVT, compared to long QT. Okay, and if you see the criteria, I don't think a stress test is not part of the any criteria. Okay, the ECG that we talked about is resting ECGs, not exercise ECGs. Okay. Questions?
Just would like to thank you for your talk. It was really excellent, since you touched on a really rare presentation of arrhythmogenic left ventricular cardiomyopathy. Thank you so much for enlightening us with this overview, and also with the update with the new guidelines about putting more specific guidelines about the ALVC in particular. And I'd like to highlight here, I've just remembered the case who had really presented with so many frequent episodes of recurrent myocarditis and permanent types of myocarditis. And we sent for genetics at the end, since really she had a very rise on her troponin on each admission, and not really responding to the medication. So, and she was found out to have also a genetic mutation related to ARVC. So yeah, we need to really have a high clinical suspicion for patients who present with a recurrent myocarditis picture to refer to genetics.
Yeah, which do you know which gene mutation? Do you remember?
I think desmoplakin is yeah, I remember well.
Okay.
Yeah.
So yes, so recurrent, we see a patient, guys, if you see a patient with recurrent myocarditis, this may not be viral myocarditis. This might be inflammation because of desmosomal protein dysfunction causing repeated inflammation. Okay, so if you see someone with repeated myocarditis, you have to broaden your thinking or your differential diagnosis and think of something genetic. Okay, because you guys see viral myocarditis more than I usually don't get to see them unless they develop arrhythmia. But if you see someone who has repeated myocarditis, then there's something, a question mark. You have to question that patient. Okay, it's a big question mark. Okay. Thank you very much. Thank you for attending. Dr. Fatma, by the way, she's an electrophysiologist from Lebanon. She's very smart electrophysiologist. So I'm happy she joined, and hopefully she can join some other next times. Okay.
Yeah, sure. It will be my pleasure. Thank you.
Thank you. Okay, guys. Thank you. Bye.
Thank you. Thank you, Dr. Mohammed. Bye bye.
Thank you, Dr. Mohammed. Thank you so much.
Thank you. Bye.